I'm Dohn, head of the Department of Neurological Surgery at the Cleveland Clinic. It's my pleasure today to introduce you to my old chief, Dr. W. James Gardner, Emeritus Head of the Department of Neurosurgery at the clinic. I've been asked to interview Dr. Gardner in preparation for the 50th anniversary meeting of the American Association of Neurological Surgeons in Boston. And Dr. Gardner is going to share with us some of his recollections of the early days of neurosurgery, something about the founding of the Cushing Society, and some other thoughts that he may have about contributions to neurosurgery and the present day situation. Dr. Gardner, how did you first get interested in neurosurgery?
Well, I graduated from the University of Pennsylvania in 1924 and accepted a 2-year internship at the University of Pennsylvania Hospital. And 3 months of that 24-month period of training was to be served in neurological surgery. And it was very welcome responsibility to take that on. None of the interns liked it. But finally, my appointment came up on April Fool's Day in 1926. And I came on the Fraser service the very day that Dr. Bunny Fay, who had been his assistant for many years, left to spend 2 years with Hill's Fire.
Dr. Spiller?
Dr. Spiller.
Oh, yeah.
My memory for names is pretty bad. So poor Dr. Fraser was left with a green, uninterested intern and no assistant. And I had to work very hard to keep abreast of things. So at the end of my 3-year tour duty, 3 months tour duty, Dr. Fraser still didn't have an assistant. And I had become very fond of him by that time and hated to see him break in another green, uninterested intern. So I offered to stay another 3 months. Well, at the end of that 6-month period, the die was cast. I decided I wanted to be a neurological surgeon, and Dr. Fraser, still not having an assistant, appointed me for his resident.
So how long did you spend with him altogether?
Well, then I spent another 3 years, made 3.5 years in all. And was to finish my training in October of 1929.
I suppose there wasn't really any set program for training in those days.
No, you just worked and did everything, including all the autopsies. And there wasn't any much lecturing. You just observed and followed instructions. What
kind of a man was Fraser?
Fraser was really quite an excellent teacher. He had a short temper, and you had to. It was physically impossible for him to compliment anybody. But as long as he wasn't giving you hell, well, you knew you were doing all right.
You were ahead, huh? So how did you happen to come to Cleveland, to the Cleveland Clinic?
Well, on May the 15th of 29, the Cleveland Clinic had a terrible disaster. The films, the X-ray department was in the outpatient department, a building on corner 93rd and Euclid, and the films were stored in the basement. Well, nobody recognized that X-ray films were a hazard in those days, and the outpatient department was built in the form of a hollow square 4 stories high. Well, it happened that on May the 15th of 29, the films caught fire in the basement and smoldered for a time, and then suddenly exploded. the composition of the films at that time was almost like celluloid, and really, but curiously, nobody realized that they were in a hazard. Well, because of the structure of this building, all the square, 4 stories high, when the films exploded, the poison, there wasn't much fire, but the poison gas from the explosion forced itself upward and into every room until the skylights blew out. By that time, it had gone to every room in the building. And it killed 126 people. And among them were the neurological surgeon and his assistant, along with 7 doctors.
Who was that? I hate to test your name memory again. Was that Ted Locke?
That was Ted Locke.
No, he
Locke.
trained with Cushing.
He was trained abroad and with Cushing.
Uh-huh.
And he was the only neurological surgeon in the state of Ohio. Mm-hmm. Well, I subsequently learned that, of course, this news was all over the world, newspapers in Philadelphia, of course. And I subsequently learned that that Dr. Fraser, when the smoke cleared away, called Fraser. They were good friends.
Dr.
Fraser in Philadelphia.
Dr. Cryle, you mean?
Dr. Cryle phoned Dr.
Yeah.
Fraser because they were good friends, both interested in thyroid disease, as a matter of fact. And asked him if he could recommend somebody to take Ted Locke's place. Well, I was unaware of this, but I learned it subsequently that Fraser said yes. He said, Charlie, I could recommend Jim Gardner, a resident who finishes his training with me shortly. And Cryle's response was, no, Charlie. He said, I've got to have an older, more experienced man. But he finally had to settle for me because there wasn't anybody else. So I came on for an interview. I was reading a paper, I remember, at the meeting of the Pennsylvania State Medical Society, which was holding its annual meeting in, what's the name of the town? Over in
Erie, perhaps?
Erie.
Yeah.
And my subject was a new procedure known as encephalography. It wasn't called pneumo then because there was no electro. Yeah. And when I stepped down off the platform, this red-headed man came up to me and he said, introduced himself, was Dr. Lauer of the Cleveland Clinic. He said, how'd you like to come to Cleveland with me and meet the staff of the Cleveland Clinic? Well, of course, I knew they were looking for somebody, and I had other plans, but I said, well, of course, I'd be happy to. So he put me in his little Packard coupe and drove me down to Cleveland and put me up at the Shaker Tavern. There I had dinner that night with Dr. and Mrs. Cryle, Dr. and Mrs. Lauer, and we had a nice evening, and they pumped me pretty dry, and I gave out willingly. And as we parted that night, Dr. Lauer said, now, Gardner, I'll meet you in the morning, 7 o'clock. We'll go down and meet the staff. So I was there, and he was ready, and we came down. He took me directly to the hospital and into a patient's room. Am I going too much detail?
No, I think this is interesting.
So where he introduced me to a young woman who had about 2 weeks' worth of hair on her head and a bulging decompression on both sides of her cerebral hernia, obviously severe intracranial pressure. And Dr. Lauer said, Gardner, what do you think of this lady? Well, I soon discovered she couldn't talk. I said, well, she has she has unlocalized brain tumor. He said, yes, but where is it? Well, I said, since she can't talk, it's in Broca's area. Broca's area, where's that? Well, I said, it's right here. He said, would you like to operate on her? Well, I said, Dr. Lauer, I'd be happy to, but I've got a schedule tomorrow morning back in Philadelphia, and I've got to get the afternoon train. Come with me. Took me up to surgery. It was all set up. Billy Lauer wasn't one to buy a pig in a poke. He wanted to see action. So here was the operating room all set up, the instruments all out, laid out on a sterile table, sterile scrub nurse with her hands wrapped in a sterile towel, and the anesthetist was waiting. Well, I was caught, so I agreed, and they had a good set of drills and wire giggly saws, and I operated, and luck was with me. I turned down the left frontal flap, opened the door, and the globular meningioma of the convexity almost rolled out on the floor. Well, I finished the operation in 2 hours and 20 minutes, and the job was mine.
They weren't used to such expedient service, I guess. Huh?
No, my predecessor was very slow and meticulous. They only had 4 operating rooms. And when he scheduled a brain tumor case, it took from 8 in the morning till 4 in the afternoon to rule. So I signed on at a magnificent salary of $6,000 a year as head of the department.
Well, maybe,
About not only neurosurgery, but neurology.
Maybe that method of interviewing people should be adopted currently.
Well, anyhow, I was signed up at the magnificent salary of $6,000 a year, and they didn't appreciate that about a month after this interview, the depression of '29 was going to happen. Well, I just signed a contract, and everybody else on the staff had to take a reduction in their salary. But they couldn't reduce mine because I just signed it. Well,
that was the start of a long association with the clinic, wasn't it?
It is. It lasted till
Till present time.
I joined the. I was retired when I attained the. What am I trying to say?
Retirement age?
Retirement age in 1963.
Yeah. Had to retire at age 65. Huh?
And retired at age 65.
Well, Cleveland has some Cushing connection, doesn't it?
Oh, yes.
Cushing, having been born here and received his early education and is buried here.
That's right.
Did you ever get to meet him?
I only met him once when there was a meeting of what is now called the Senior Society, the Society of Neurological Surgeons, met with Frazier in about, must have been in about 27 or 28, long in there. And Cushing was among the visitors, and I remember he stood up in the stands and whispered criticisms of Frazier's technique to the other guests. Just loud enough so Cushing could hear, or so Frazier could hear. And that's the only time that I met him. Oh, I think I'd seen him at a subsequent meeting before coming to Cleveland.
Were Cushing and Frazier pretty close friends, or
No.
aside from that incident?
They were well acquainted with each other, but you couldn't call them friends. But he was less unfriendly than Walter Dandy,
Was to Cushing, huh?
the Cushing. And here I was located in Philadelphia, just halfway between Johns Hopkins in Boston, and the arrows were flying over my head in both directions.
Well, now, you were listed as one of the founding members of the Cushing Society, or the now called the American Association. You have any recollection of that, what it was that led to that founding of that society?
No, except that I was invited to attend the founding of it, the first meeting in which it was discussed, and I had some conflict that wouldn't, I've forgotten anymore what it was, but I couldn't attend. And I didn't realize that they were carrying me on the roster as a founding member for some time after that. But actually, I had been a member of the Society of Neurological Surgeons for a few years, and then in '41, all of the members of the Society of Neurological Surgeons were invited to join the Cushing Society, and most of us did.
Mm-hmm. You've had the opportunity to do many things in neurosurgery, and I think that you've made many important contributions to neurosurgery, where we all know that. What do you think is your most important contribution?
Well, I've always considered myself extremely lucky to come to the Cleveland Clinic, where everything was available or could be made available. I had, as a matter of fact, I did my first bit of research as an intern back in Philadelphia, when I studied the effect of hypertonic glucose on intracranial pressure. I made a tracing then on a smoke drum. I made my own tambour and showed the arterial pulse waves in the fluid and how they're abolished in the spinal subarachnoid block, and noted that the effect of 25% glucose was rather mild and transient on reducing it. And that material was subsequently presented at a meeting of the Association for Research in Nervous and Mental Diseases, in a meeting which met every year in Atlantic City. But the thing that impressed me was the fact that here was an institution where facilities were just terrific. Our own hospital and laboratories, and all the help that one could require so far as research is concerned. A good functioning research division and things to work with, and I was just delighted and thought myself very lucky to join. And I've been happy ever since because of this long association. Shortly after I came here, I think my first contribution was after joining the staff. Well, it had to do with chronic subdural hematoma. An explanation of the latent interval. It was well known that so-called chronic subdural hematoma was a result of a mild, frequently unrecognized head injury or forgotten. And the symptoms wouldn't develop until about 3 or 4 weeks later. And then the headache would start. Well, I showed that while cerebrospinal fluid and blood have the same total content of molecules. What am I thinking about? When you put a tube of the patient's of a dog's blood in a cellophane semi-permeable sac and immersed it in the patient's cerebrospinal fluid, the sac would swell because the cellophane is impermeable to protein in the plasma protein, and therefore there was a colloid osmotic tension attracting the cerebrospinal fluid into the cellophane sac. And it seemed logical to me that when the blood escaped over the convexity and clotted, a membrane would form around the clot, and then the clot would subsequently liquefy and and the protein would attract cerebrospinal fluid through into the sac. So that was the first bit of research that I did at the Cleveland Clinic.
Do you think that was the greatest contribution? You know, you've become so well associated, so well known for your work on the dysraphic state, and of course that probably for the fellows that have trained with you, that's a memory that maybe stands out closest in our minds.
Mm-hmm. Well, that was, I've always been very lucky. That was pure accident. When I came...
With a little serendipity, maybe.
Yes, that's right. When I came to the clinic, they had a setup on the surgical pavilion which you could take an upright view preoperative view of a patient's chest. Sometimes they're scheduled for operation. They discovered they had perhaps needed a chest x-ray, and they could make it right there in surgery. Well, this upright buckery was perfect for pneumoencephalography. If I wanted to do a ventriculogram, I would have to anesthetize a patient, do the air injection, close the wounds, then send him down in the elevator to the basement, across 100 yards of corridor, and up another to the outpatient department where the regular x-ray was made, in which the films could be made with the patient horizontal. Well, that was a risky business. And therefore, it made pneumoencephalography actually safer than ventriculography. And I began to do it even in brain tumor suspects and even in patients with papilledema. However, if there was papilledema, I always made a precautionary trephine so that we could tap the ventricles if the need arose. So we discovered, we even used pneumoencephalography in patients with cerebellar symptoms, for which I would have been roundly criticized had I announced it at that time. But we discovered that the pneumoencephalographic picture of a cerebellar tumor was a hindbrain hernia in the cisterna magna and a lack of air in the ventricles. So one day I operated upon such a patient for a presumed cerebellar tumor and found that it was a congenital hindbrain hernia. And also noted that the spinal cord was cystic. So I thought, well, this is a case of syringobulbia causing the posterior fossa signs with an asymptomatic syrinx. So about 6 weeks later, I had a patient with classic syringomyelia and no hindbrain symptoms. So recalling this experience, we did a pneumoencephalogram. And here was the same picture. A hindbrain hernia and no air in the ventricles.
About what year was that? Do you recall?
39. Well, I think it was some 10 years later, yes, about 10 years later, that Bill Nozick assembled our series and found that we had pneumoencephalograms in some 20 patients with cerebellar tumor, and that was the picture. And none of them got into trouble although in some cases we did tap the ventricle, of course, to reduce the pressure. So that established for the first time that the cause of syringomyelia is not in the spinal cord, but in the hindbrain, because the obstruction of the fourth ventricle causes the pulse waves in the ventricular fluid to spurt into the upper end of the central canal and down into the syrinx. And subsequent experience, of course, has established that. But curiously, the pathologist can't demonstrate that communication, but very rarely. And that has led to the thought that there is a non-communicating form of syringomyelia. Well, the reason that the pathologist can seldom demonstrate the communication is because there's been some work done that shows within 8 minutes of arrest of the circulation, the extracellular fluid of the brain shrinks by 75%. So that, and this shrinkage of the extracellular fluid, since it communicates freely with the ventricular fluid, causes a shrinkage too of the central canal. That's why the pathologist can't demonstrate the communication except in very rare instances. Actually, there's no such thing as non-communicating syringomyelia.
You've always had a, what seemed to us as your students, a very investigative bent. And yet, many neurosurgeons, probably most neurosurgeons, go through their career without exhibiting this. What is it that creates that curiosity and the feeling that you have to investigate? Is it, you think it's something that's just born in a man, or did you have this instilled in you by anyone? Was there somebody in your life that kind of gave you that?
No,
that frame of mind?
My father was a fine person, a general surgeon, but I recall reading in the McKeesport Daily News, they published a column 50 years ago today, and they went back over their files and they found that my father had 50 years ago today had transplanted the nerve from the leg of a dog into the arm of a human.
Is that right?
But that's my father died when I was, both my parents died of tuberculosis when I was in high school. So I was not totally unaware of that at the time. But there's one thing that stuck in my memory about birth defects. When my first year of internship, I think one of the very first patients that I encountered when I came on Dr. Fraser's service as an intern was an infant of the famous DuPont family in New Jersey who had hydrocephalus and a myelomeningocele. Well, I'm not sure now whether it was myelomeningocele or a meningocele, but it was a swollen watery tumor of the lower back. And it seemed to me that the hydrocephalus was the cause of it. And I investigated a bit, and I found that in 1769, the famous Italian physician Morgagni has stated that these watery tumors of the vertebra are the result of the pressure descending through the tube of the spine and pressing the bones of subdural. Well, that seems so logical to me, but even at that time, the belief was very commonly held because of the great von Rechtinghausen's dictum, who examined one of these watery tumors with a microscope and found it was an open neural tube, and stated, therefore, in his article in 1886 that these or that Morgagni was wrong, that these watery tumors are the result of failure of closure. And I discovered that everybody had gone along with that idea. But I just couldn't believe it because it's just against the rules of hydrodynamics. Why would a tube that never closes become overdistended? So that idea has been with me ever since then, and that's the reason. Then in 1925, Cushing published gave a lecture, which was published in 1925 in The Lancet. And he entitled it The Third Circulation of the Brain. That title has intrigued me ever since. And he pointed out that the brain is the only organ in the body that has such a third circulation. Of course, in those days when we only had the light microscope, he was unaware of the fact that the final distribution of this third circulation was into the brain substance. It went through the ventricular walls into the brain and actually did nourish the brain, where as its contents were metabolized, used up in nourishing the brain, they were replenished from the protein-type cerebral capillaries. You see, the brain, which receives 20% of the output of the heart, does not pulsate. Of course, if you open the skull and look at the brain, it does pulsate. But that pulsation is an artifact produced by the cranial defect. It was shown down at Bethesda in some experiments, and this article, by the way, was published in the very first issue of the Journal of Neurosurgery. These authors removed the whole calvarium from the monkey's head, including the dura, and then replaced the calvarium with a lucite calvarium, which was made to fit very snugly. And they could keep these animals alive for months and watch the brain. And they found out, when they looked through this lucite calvarium, that the brain did not pulsate under these circumstances. Therefore, a cranial defect is an artifact which allows a pathological pulsation of the brain. And furthermore, when the days of tantalum cranioplasty came along and cranioplasties were done more frequently, it was shown that a pulsating brain can cause symptoms. If the cranial defect is wide enough to allow the brain to pulsate, the brain will deteriorate, and it may cause convulsions, progressive paralysis, aphasia, and all sorts of symptoms, which will respond immediately to closing the defect. And therefore, conversely, in syringomyelia, the pulsations of the intracranial subarachnoid fluid normally escape freely through the foramen magnum and are damped by the expanding dura, spinal dural sac, which damps its expansibility, damps these pressure pulse waves. But if there is a hindbrain hernia partly obstructing the foramen of Majandi, this damping effect is largely lost. And under those circumstances, the pulsations of the ventricular fluid are funneled into the central canal. Well, this pulsation, and therefore the central canal pulsates, and all syringomyelia, symptomatic hydromyelia, been present since fetal life. But this pulse wave, while it's mild, occurs more than 2 billion times in the course of a year. And therefore, that explains why it takes so long for the symptoms to develop. And furthermore, there's some work that indicates that congenital hindbrain hernia are present in 1.8% of presumably normal individuals. Because during World War II, they established a very favorable nursing facilities for traumatic quadriplegics from World War II in Toronto. Lyndhurst Lodge, it's called. And they found that they were taking care of healthy young male adults, obviously healthy because they were war veterans, that of the traumatic paraplegics, 16 out of a total of 400 and some, anyhow it amounted to 1.8% of their traumatic paraplegics developed syringomyelia, cervical syringomyelia. Well, they blamed it on the trauma, but actually the accompaniment of a traumatic paraplegia, there's nearly always a complete subarachnoid block. So the traumatic subarachnoid block, the symptoms would develop anywhere from 1 to 15 years after the trauma. I felt that it was the presence of the block that removed part of the damping influence of the dispensable sinodura sac, because the lumbar sac is the largest part, and that's where most of the damping effect occurs. Mm-hmm. So they got along all right with their congenital hindbrain hernia, which is the anatomic substrate of syringomyelia. But years later, from the pulsating spinal cord, which normally doesn't pulsate, just as the brain doesn't pulsate. But like the brain, if it's allowed to pulsate, it will deteriorate.
Let me ask you, when you finished your training, there probably weren't too many neurosurgeons in this country, were there?
I was the only one to hire for some years.
Probably not many between the East Coast and Chicago, I bet.
I don't know whether there was one in Pittsburgh or not. There was very soon after, I think. Mm-hmm.
Now there's something like 3,000 neurosurgeons. When you think back, did you ever envision that there'd be such a growth in this specialty?
Never thought it possible. And in a way, it is, you might say, I don't like to say unfortunate, but whereas in my heyday, I was operating on 50 cases of tic douloureux every year, and became, naturally, practice makes perfect, and we discovered that, well, of course, Dr. Fraser's favorite operation was for tic douloureux, and the operation in those days was total section of the sensory root. In the earliest days. But by the time I came with him, he had learned first to spare the first division. And then subsequent to that, he discovered he could recognize and spare the motor root. I think it was in 27 that a patient arrived from South America, a very prominent woman, very wealthy person, upon whom he had operated some 7 or 8 years before and divided the right trigeminal nerve for tic douloureux. And here she was with tic douloureux of the left side. Well, Dr. Fraser, she'd had this operation before Dr. Fraser learned to spare the motor root, so she had a total motor and sensory paralysis on the right side, with atrophy and paralysis of all the masticatory muscles. Well, by this time, Fraser was pretty confident that he could spare the motor root, so he advised a subtotal resection of the fifth nerve on the left side. Well, the morning of the operation, the air in surgery was really tense. But Dr. Fraser did a beautiful job. He exposed the sensory root. He divided the outer 3/5 or 3/4 at least of the sensory root and spared the motor root. At least he thought he had. And when he stimulated the motor root with a thoracic current, the jaw twitched. So he heaved a sigh of relief and told me to close the incision. He stepped out. Well, I closed the incision and took off the drapes. And to my horror, the lady's chin was resting on her manubrium. So I sent for Dr. Fraser, and boy, he hit the ceiling. Did I say he stimulated with the thoracic current?
Yes.
And he called for the dentist to come up and wire her teeth together to close her mouth. He couldn't stand to look at her. So, Fraser was in a terrible disposition for the next 10 days. Finally, about 10 days later, I detected a little contraction when I told her to clench her teeth in the masseter muscle on the left side. So I hurriedly called Dr. Fraser. We took off the wires off the teeth, and she was able to close her mouth. From then on, life was easier.
Well, you had a lot of experience with tic douloureux, didn't you?
Oh, yes. One unfortunate thing, in one way of looking at it, is that there's so many neurological surgeons in the world today that no one of them gets enough experience with the so-called radical operation. As a matter of fact, it's no longer radical. We've stopped dividing the nerves for 20 or 30 years ago because we found it wasn't necessary. That you could expose the sensory root in the middle fossa, open the, what's that door?
Duropropria?
Duropropria. That's not what it's called. That's what it's called, but that isn't what it is. Duropropria means dura proper. And this is not dura proper. This is a reflection of the dura. But the
Gesserian,
what's the name of the
cava mecale?
Cava mecale. We could incise the dura over the sensory root to open the cava mecale, and you could. By that time, we realized that most cause of most trigeminal neuralgia was in pressure on the nerve in the posterior fossa, and we would take a hypodermic, a needle of a syringe, and bend the tip of it so it would kind of squirt around the corner. The purpose being to fill this 10 cc syringe with ringer solution and spurt it back through the foramen trigemini into the posterior fossa, the dural foramen there, into the posterior fossa, in order to separate the interacting fibers, which are obviously the cause of tic douloureux. And this operation was tremendously successful, very successful. Sometimes it could be repeated, and if it had to be repeated the third time, we'd divide some of the fibers. But these patients had no sensory loss with complete relief. I just recently saw a woman down in Louisiana that I had done this operation on 17 years ago. She hasn't had a pain since.
You've early on had the opinion that trigeminal neuralgia and hemifacial spasm had a similar mechanism as their cause.
There's no question about it.
Well, when was it that you first began to operate on hemifacial spasm?
I'll look up the date before we meet again. The idea occurred to me because I had this young lady from Akron who had classical hemifacial spasm, but in addition, during the spasm, she would have a sound in her ear. Well, of course, that could be due to innervation of the tympanum through the seventh nerve. But she said that sometimes she was dizzy or nauseated during these episodes. And furthermore, she was beginning to lose some hearing in that ear. Well, I decided this could be explained by something pressing on the seventh and eighth nerves. So I operated upon her, and here was a loop of an artery compressing both seventh and eighth nerves, an anomalous loop, probably the anterior cerebellar artery. Yes, anterior cerebellar artery. So I packed it away with a piece of gel foam and stopped her hemifacial spasm. It didn't improve her hearing, but she had no more dizzy spells and no more hemifacial spasm. And that was just a lucky incidence in which there were eighth nerve symptoms accompanying the hemifacial spasm. Well, then it developed that hemifacial spasm and tic douloureux can occur on the same side. And in cases in which that is true, a lesion has been found compressing both the trigeminal and the facial nerve. And I have seen two cases. Of course, there are only 3 nerves in the body that are subject to pain characteristic of tic douloureux: the 5th, the 7th, the 9th, and the 10th, 4. Now those are mixed nerves, both sensory and motor, which in addition have a parasympathetic component. It's never been proven in the trigeminal nerve, but I'm sure it's there, because the paroxysms of tic douloureux have all of the temporal characteristics of a parasympathetic reflex. That is, they occur in response to a stimulus. They follow and outlast the stimulus. They clear up after a certain interval of time, just minutes or seconds. And fourth, they're subject to long remissions. They can be subject to long remissions spontaneously. And there's no impairment of sensation. So that the pressure against the nerve, I feel, has to be light enough to bring the fibers so close together that there is atrophy or dislocation of the myelin sheath, which is a sort of a semi-fluid oily substance, so that the axis cylinders get close enough together that there's a transaxonal excitation. Now, with long compression, the sheath, the myelin sheath, will be reduced. But theoretically, at least, removing that compression, even momentarily, by squirting the nerve and separating the fibers, it may take it months or years to get close enough together again to allow this cross-stimulation. But there must be a parasympathetic filament in the trigeminal nerve, because it has all the characteristics of an autonomic reflex. I recall very distinctly Mrs. Diamond, who had horrible glossopharyngeal neuralgia. It's tic douloureux, same characteristics. And in questioning her, she said, I asked her what seemed to bring it on. Oh, she said, I've got to be careful what I eat. She said, if I take anything that has a tart taste, it brings it on. She said, I can't even bear to think of a pineapple. Oh, there it goes. She grabbed her face.
Yeah. Now, during the time that you were at the clinic, you educated, trained a lot of neurosurgeons. I dare say 40 or more.
Yes.
Do you want to share some of your views about training of neurosurgeons?
Well, back in the early days, he just picked up what he could learn by watching. There wasn't any organized lectures and that sort of things. And the first man that I trained was Wally Hamby. He came down here from Buffalo as a general surgical resident. I think perhaps he was assigned to my service first. Or anyhow, no, I guess not. Anyhow, in the course of his training in general surgery, he was rotated through neurosurgery. That was probably the way. And he became interested and decided that applied for a residency, and he was my first real resident. Prior to that, various surgical residents had rotated through, but in those days, the resident learned by watching. The patients were all private patients, and I didn't feel free to turn over too much work to them, at least until their third year. And there are some residents that can learn by watching and then go out and do a very credible operation without ever having placed a stitch. But I recognize that others have got to have some experience in handling and tissues, and they learn, in other words, by doing mechanically.